give me 1 minute, putting it on YouTube, which is necessary, and spreads it wider, as Ahmed will tell you. Okay. Okay, I'm going to bump you off the screen there, Dr. Abu Bakr, because I need to introduce Ahmed first. Okay, and you can get back on it later. Okay, Abu Bakr, don't go on. I'm going to get you off. You need to stay off it. Okay. Okay, ready, Ahmed?
Yeah, I'm ready.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon from Miami Beach. This is Dr. John Bennett for Neurosurgical TV. We have the honor of televising collaboration between Yemen Walter Dandy Club as well as Sudan. I guess, I don't know if it's the Walter Dandy, but we're connecting with Sudan with an old friend, Abu Bakr. I'm going to introduce the program to a resident of neurosurgery in Yemen. A gentleman is very active on the internet and very tech smart. Hello, Ahmed. How are you doing today?
Hi, dear John. How are you? I'm so fine, and I'm so honored to be with you here in Neurosurgical TV. First of all, I'm so honored to introduce myself. Here is Ahmed Al-Ghanmi, the president of Walter E. Dandy Neurosurgical Student Club of Yemen. I'm also marketing administrator at Abdul Rauf University of Neurosurgery, which is considered the first online academic degree in neurosurgery worldwide. First of all, I would like to introduce my colleague from Sudan, Abdulrazak Hassan, in order to introduce his speaker. Hi, Abdulrazak, can you hear me? Are you around?
Yeah, I can hear you.
Yeah, you can go ahead. You can introduce your professor.
Yeah, how are you guys? I'm Abdulrazak Hassan Aliyu, the president of Walter E. Dandy Sudan. We are really appreciate for the invitation for the collaboration of webinar from Dandy Yemen and Dandy Sudan. And I would like to introduce our speaker, which is Prof. Abubakar Daraj, consultant neurosurgery and president of Walter E. Dandy Neurosurgical Club, and the president of Sudan Association of Neurosurgeons. He would like to give us a lecture about role of neurosurgery in stroke management. Thank you so much.
Okay, thank you, all of you. Thank Bennett, thanks colleagues from Yemen, Ghanami, and thanks for the Razik. I'm very happy to be here to speak, especially to the residents and students and to all medical professionals about important problems that face neurosurgeons, neurospecialists, neuromedicine, and in all medical fields. This is very important topic and should be taken carefully by all of these candidates or medical staff. So cerebral stroke is a clinical problem affecting the vascular components of the brain. We know that the brain is the most important part in the body. It controls all the functions of the body, and it depends mainly on the blood supply. And if the blood supply to the brain has been interrupted or escaped away from the vessels and get outside and burst or damage the brain, it will be a big problem because there's degree of cut of the blood from certain areas associated with compression of other area and damage of other areas. So this is a big problem and should be solved as soon as possible. The problems mainly are either defective blood supply, that means cut of the blood supply, or diminution, severe diminution of the blood supply from certain areas of the brain. And we call this, if it is mild, we call it ischemia. And if it is severe and led to death of cells of the brain, we call it infarction. The second other problem rather than cut is leaking of blood outside the blood vessels, which is known as hemorrhage. We know that hemorrhage, there's no space for hemorrhage in the brain. And once the blood come out from the vessels to the surrounding brain, it either cut through the brain tissue, and this causes damage to the tissues, or burst them, or collect in the cavities in the brain. And or all of these, maybe the three, may be present. First, we are going to speak about the cerebral ischemia, which is reduced or cut of the blood supply from certain areas of the brain. This might be intermittent. Sometimes it occurs and it has been solved by the body, and this is called transient ischemic attacks. And transient ischemic attacks are warning, are a degree of warning from the body that there is a problem, and this problem might spread and become bigger than this, which is the second type, is the permanent cerebral infarction, or permanent cut of the blood from certain areas of the brain with subsequent death of this part which has been deficient of blood supply. Also, we have the bleeding might be coming, or blood might be coming from the arteries or sometimes from the veins. It's either arterial or venous bleeding. The arterial bleeding is so aggressive because the pressure in the arteries is high, and the venous is somewhat less aggressive than the arterial bleeding. But both sides, the arterial side or the venous sides, might bleed. Another problem is venous cerebral hypertension. And this means that it jeopardizes of the venous outflow from the brain with subsequent collection of fluids and sometimes rupture of some small blood vessels with subsequent bleeding. And this also leads to dysfunction in the brain. This diagram shows you here, this is the brain, and this is the blood vessels here in the middle. The blood vessel has been torn with subsequent escape of the blood outside the vascular compartment.
Sorry, Professor Abu Bakr.
What? Your screen is not shared here.
It's not shared?
Yeah, we can see your screen.
Yeah, please share your screen, Abu Bakr, like you did before. Okay.
Is it shared now?
Yes. Types of strokes in the brain.
Yes. Yes.
Okay.
The figure to the right side represent partial or small vessel occlusion, and this represents transient ischemic attacks, in which, in such condition, the patient will present with features of deficient blood supply from area of the brain, and the dysfunction in his body will be according to which area has been involved. and this will be resolved by the body, and the patient become normal again. And this is a warning for a major problem that might occur. There is something sending blocking pathologies to the brain, and the pathology did not completely occluded the vessel. The second one is the one to the left, and this represents obliteration or blockage in one of the major vessels, and this will end with death of that part because no blood supply is coming to that part, and this with definitely severe dysfunctions in form of motor, sensory, visual, intellectual, according to the area supplied. In the middle, represent that blood vessel has been torn, and some of blood came outside from the vascular compartment into the tissues or the cavities of the brain. This is the same. It represents in the right side the infarction, and the area here looks dark because there are no blood supply, and the blood which is already present in the tissue has been deoxygenated. And to the left side, to the right side is escape of blood from the vascular compartment. The causes for acute and chronic ischemia, there are many causes, but the most major that you find in the patient is either hypertension. The patients with hypertension are highly subjected to develop these problems. Or atherosclerosis. Atherosclerosis, we know that atherosclerotic materials, when deposited in the blood vessels, they are going to obliterate or to either partially or completely obliterate blood vessels and lead to ischemic attacks. Vascular emboli are other materials, usually not from the blood vessel itself, maybe a tumor in the heart, maybe other materials. And these lead to also obstruction when gain and access to the circulatory vessels inside the vessels, they lead to obstruction of these vessels. Thrombosis is clotting or of these blood vessels, inside blood vessels, or the blood inside blood vessels, and this lead also to obliterations of the vessels from the vascular compartment due to loss of fluidity of the blood and the blood change into clot. The other problems are vasculitis, inflammation of the blood vessels, and this is usually an immuno problem, and this leads also to narrowing of the blood vessel, and the blood will be jeopardized or blocked. Other causes for hemorrhage are vascular pathologies like weakening of the blood vessels. We know cerebral aneurysm, and cerebral aneurysm are weak area in the blood vessels that has been thinned out and bulging, and the wall has been thinned, and this might rupture, especially in patients with hypertension, and also arteriovenous malformation, in which there are weakening of the large area of the blood vessels, and the vessels are too weak, and their wall are too weak, and they are liable to rupture or to get blocked. Venous occlusion also, especially of the major venous parts of the body, of the brain, I mean, will lead to jeopardize of the outflow of the blood from the brain and increase the pressure in the tributaries that send blood to these major sinuses, and this will lead to blockage of the outflow, and in the same time increases the pressure in the venous vessels, and sometimes they rupture. And this also leads to bleeding. Also, the bleeding diseases or problems like hemophilia, thrombocytopenia, and Christmas disease, this might lead to that clotting mechanism of the blood has been jeopardized, and even if a small injury has been made or incurred in any of the blood vessels, this will lead to escape of the blood for a long time without being controlled. And also other pathologies like tumors and cysts sometimes has weak blood vessels, and the blood will rupture. Blood vessels of these tumors will rupture with accumulation of the blood inside these tumors, and sometimes rupture of the tumor itself and escape of the blood into the other parts of the brain, whether brain tissue or cavities. The diagnosis of this condition is depend on clinical assessment of the patient, and clinical assessment to see the patient complaint and the patient deficits, and to see whether the patient has history of the different predisposing factors, hypertension, bleeding discrepancies, or so as to get access to the pathology. And we depend also on radiology in delineating the area in which there is a bleeding or infection. So we use usually CT scan for acute hemorrhage. CT scan can diagnose acute hemorrhage from the moment of the occurrence of that hemorrhage, and it will be presented as hyper dense area in the site of the hemorrhage. Also, we can use MRI, especially diffusion studies, for acute infection, because acute infections will not appear in the CT scan except after a long time, and we have to use the early hours in trying to reverse the condition, that to open these vessels. So if we depend on CT scan on diagnosing of acute infection, it will not occur, maybe taking 2, 3, or 4 days. So in patients in whom we suspect acute infection, we should go directly to MRI with diffusion studies. It will diagnose the condition since the start. Also, CT and angiography and MRA to know where are the vessels which are occluded. So these are the primary investigations, but other investigations like a study of the clotting factors, study of diabetes, study of other different conditions that might lead to this major problem also are important. But this for direct diagnosis of the condition and its cause. So here you can see this is CT scan, and you can see here this big area of hypo-intense brain without any sulci or gyri as seen in the other side. It is all is expanded because no sulci or gyri here are present. And you can see that there is midline shift. The midline shift is the false and septum pellucidum here has been pushed to the other side. And this is feature of acute ischemia that you can diagnose in the early days of the condition. But nowadays it's better to do MRI before this appear, because if this appears, the condition is almost permanent or semi-permanent, and you cannot reverse it easily. The CT scan to the right side here, you can see here the chronic infarction is black area like this without any pressure manifestation, because the ventricular system is wide towards the area of the infarction. It has been pulled to the infarcted area, and there is no midline shift and ventricular enlargement. On the other side, it looks normal. So this is a permanent condition, and you cannot change it to normal. In this image, you can see here, this is CT scan for hemorrhage, acute hemorrhage. You can diagnose acute hemorrhage from the start. And you can see here also a big, irregular, hyperdense area, and is surrounded by hypodense area, which represent edema around the hemorrhagic area. And there is push of the midline structures, the septum pellucidum, and the ventricular system to the other side opposite to the hemorrhage. And you can see here also the bleeding in the occipital horn of the left ventricle, and this denotes as the blood ruptured into the nearest cavity. It find here. This is acute hemorrhage, can be diagnosed by CT scan, and no need for MRI from the start. And in the image or the section of the image on the right side, you can see this is a hematoma. It is in the cerebellar area, because this is the edge of the tentorium here and edge of the tentorium here. And you can see here there is no fourth ventricle and there is no aqueduct. All these are obliterated. Aqueduct is open here, slightly, but the remaining part is occluded, and so there is dilatation of the ventricular systems. And in this case, you find there is degree of hydrocephalus. The pathology has been changed, is combined bleeding and led to hydrocephalus, and the treatment should be also combined in this case. This is the MRI diffusion studies, and this can diagnose the ischemic attack or infarction from the area and before it enlarge. So this is in 5 hours, and if you have done treatment here, you can save big part of the brain. But if you wait 13 hours, 1 day, 2 days, each time the infected area will enlarge. So early intervention, early diagnosis, and early intervention is very helpful to the patient. This is MRI flare studies, and also shows you the delineation of the infected area. The management is either is tailored according to the patient condition and the patient pathology. You can manage the patients conservatively in certain conditions, but other patients might need surgical intervention, and some might need endovascular intervention. The conservative or the palliative management will be in the form of sedation and analgesia. If you decide to do palliative intervention, sedation, oxygenation. We need oxygenation because the area infected or even with hemorrhage, although you can find that the oxygen saturation in the peripheral part of the body, which is done by pulse oximeter, is normal, but in the brain it is not normal because the brain has been jeopardized. If you have a cerebral pulse oximeter, it gives you better evaluation or better help for that patient. So don't depend on peripheral saturation only in saying that the patient has good oxygen. We mean good oxygen here in the peripheral, in the fingertip, but not in the brain. So you have to give the patient oxygen if you have no cerebral pulse oximeter. sedation and analgesia are important because the patient, if he is conscious, will be irritable, and this might increase his blood pressure and increase his problem. Multivitamins and omega-3 are also helpful to give some nourishments to the cells around the hemorrhage or around the infection, because in this case, because they don't receive any blood, or receive blood jeopardize circulation, and this will give them less nourishment. And so if you increase the vitamins in the blood, it will be better for that tissues to receive an extra vitamins or omega-3, which are important for the brain cells survival and functions. Are you hearing me?
Yes, yes, I'm sorry. We had some interference. Go ahead.
Also, nimodipine is very important in hemorrhagic. Is very important in hemorrhagic insults or stroke, because nimodipine, we know that the products of the blood will cause product degradation products released from the hemorrhagic area will lead to generalized cerebral vasospasm. And this occurs usually in the second week from the incidence of the bleeding. So we have to prevent that by giving the patient nimodipine or nemotop, besides the oxygen and omega-3 and multivitamins and sedation to the patient. Also, we have to control the blood pressure, especially when there is an elevated blood pressure, because elevated blood pressure, if it is hemorrhage, will lead to increase hemorrhage. And if we drop it, function of cerebral perfusion in other areas. So we have to keep it in a little bit elevated condition, and not to lower it to normal or below normal. That is not good for the cerebral circulation. And after that, later on, physiotherapy, I think physiotherapy, we have to start it from the incidence of the insult, and not to wait for a couple of days or a couple of weeks to start physiotherapy, because this will, the joints, the muscles will get dysfunctioned and will get atrophied, and we have adhesions in the joints. And this, even if you start the treatment after a few days, physiotherapy, I mean, it will be painful to the patient, because there are some condition. The patient might be subjected to deep venous thrombosis, and even the movement of the limbs will send sensory impulses to the brain to recover the area involved. If you wait it till these areas, the areas will atrophy in the brain if it not receive any impulses from the periphery. So you have to start physiotherapy and from the start, and not to wait for a long time. Also psychotherapy for the patient, because the patient, if he is cooperative and is understanding his problem, and it will help him to recover rapidly. Also occupational therapy for the patients who are doing certain functions, so as or certain jobs, because if you leave them, they might lose their abilities and cannot go back to normal life. Surgical treatment for ischemic stroke will be in many forms. Sometimes we do decompressive craniotomy, because as you have seen in the various CT I have given to you, that there is expansion or swelling in this area of the stroke. And if we left that swelling, it will press the other normal brain. So we might have got that part of the brain will be hopeless, because it is infected already. But if it compresses the other normal brain, it will cause also that normal brain to be functionless. And so we can do opening of the skull, wide opening, and opening of the dura to allow the brain to expand into outside and not to the inside, to the remaining brain, and so as to damage that part of the brain. So that is the role of decompressive craniotomy and our craniotomy, and it will be helpful if it has been done so early. Carotid endarterectomy, this is helpful in patients with atherosclerotic endovasculitis, and this will cause jeopardize of the circulation, and you can open that vessels by carotid endarterectomy. Also, nowadays they are using stenting through endovascular way. We can also use cerebral revascularization. We should study the cerebral circulation, and that is usually done by the radioactive oxygen, because the circulation is going parallel with the oxygen. And you can give the patient radioactive oxygen and by special sensitizers to know which areas are involved and which vessels are supplying that area. And so this is very helpful, especially in generalized ischemia before infarction or before intermittent ischemia. And so to reinforce or to supply the circulation by additional blood from other areas. And you have to know that if the amount needed is less than 25, that is called, we need in this case to supply through low flow anastomosis. And if the need is more than 25 or more than 50, we have to do high flow anastomosis. In anastomosis, we are taking a vessel, usually from the scalp, for low flow anastomosis, for example, superficial temporal, and we do opening in the terminal areas and to connect that vessel to the middle cerebral vessel. And that will increase the blood supply in the territories of this middle cerebral artery. And we can do it in the posterior circulation by using the occipital artery. And we can do anastomosis utilizing saphenous graft. And if it is high flow, we can connect this carotid to the saphenous to the brain. And also in certain diseases like moya, we can use omental transfer or non-omental transposition, that to transfer the omentum through skin tunnel from the abdomen up to the brain, and to implant that area, that vascular area, into the brain tissue. And this will help to increase the blood supply. There will be a new vessels formed and will increase the blood supply in that area. These are types of anastomosis. Here you can see this is occipital artery. It has been connected by a saphenous graft to the middle cerebral arteries, and you can use here the superficial temporal and to connect it to the by opening the skull and doing a vascular connection, anastomosis. And you can use also the saphenous to take it from the leg and to connect it through from the carotid to the brain under through the skin. And this will help to revascularize the brain or reinforce the circulation in the brain. Also, you have endovascular solution for the stroke. You can do embolectomy through the endovascular device, and this will help to open. But that should be done so early. If you have facilities and prepare for such condition, you can do that. And injections of thrombolytics like streptokinase or urokinase, you can do it directly or through the endovascular procedures. And you can do also stenting, especially for the vessels narrowed or narrowed by the atherosclerotic patches. You can do this stenting to put a stent in the vessel or to widen it by expandable stent, and coiling for aneurysm, because aneurysm sometimes are narrowing the circulation. And this is also needed for coiling for the bleeding aneurysm. For the hemorrhagic stroke, you can do craniotomy or bear hole evacuation. I mean to open the skull by a small bear hole if the hematoma is near to the surface of the brain. You can evacuate it by bear hole if you have no facilities. I mean sophisticated facilities, as you can see later on. And you can do also by craniotomy, that if the area is wide and you don't want to you want to evacuate all this hematoma, you might do it by multiple bear holes or big craniotomy. You can use also external ventricular device, and this is done for deep bleeding, that you are not going to cut through the brain to reach the bleeding. So you have to cut a small area by passing the catheter of the EVD and to the hemorrhage, and then to evacuate the hemorrhage. This is done when the bleeding usually is inside the ventricles. And in these cases, you can do that. But it is liable for blockage and needs revision, needs sometimes washing and reopening of this, but can be used. You can also use endoscope in evacuation of hematoma. And the role of the endoscope here is by reaching the hematoma in the long axis of the hematoma, and then to suck the bleeding by the endoscope. And you can use a new method, which is called cerebral corridor creator. This is the device. You can introduce it into the hematoma and then to evacuate the hematoma by this device. This is a device of the cerebral corridor creator. You can see here is a syringe, and this syringe is connected into a catheter, and this is a cannula, and this is the trocar of the cannula, and this is the corridor. The corridor is formed from transparent plastic tube, and we introduce this. First, we introduce the cannula to be sure we are inside the hematoma, and then to introduce the cannula having a balloon here. And then we are going to inflate this balloon by this syringe, and then introduce the corridor, and so to go with the balloon inside the ventricle and or the hematoma, and then to introduce the corridor through that above that balloon. And then once you are inside the hematoma, you remove the cannula and you deflate the balloon, and you are inside the cavity of the hematoma. The hematoma will come out. After that, you can introduce your endoscope through this corridor, and then you can wash, you can suck hematoma, you can control bleeding by diathermy. Here is one of the procedures of the cerebral corridor creator operation. I hope the internet helped me in showing you this video. Here you can see here the corridor. We are introducing the cannula through the corridor, and the cannula is containing a balloon here. You have inflated the balloon, and then we are going to introduce the corridor above the balloon, so as not to cut any blood vessels. Here, when we deflate the balloon, the blood is coming out. And then we are sucking the clots. You can see here the clots are sucked out. And then to wash with normal saline and sucker to suction. And after that, to introduce the endoscope. You can see here, that is the endoscope. Through the corridor, we are going to use that endoscope. I don't know if it works. Oh, yeah, it is working. We are introducing the endoscope. And the corridor here will help you to be guided in certain area and to not to damage the cerebral tissue around by coming and going inside and coming outside. So the corridor is fixed. You can see here that are the remnants of the hematoma, and we are using here the suction to suck, and you can see that the cavity is almost not having any cerebral blood clots. And you can, after wash, if there are any bleeding vessels, you can control them by special therapy through the corridor. This is a conventional way. Here we are doing for this hematoma. It is in the frontal area, and fortunately here the hematoma is reaching to the skull, down the skull, and you can open the here at this area. So we have opened by craniotomy, and we have seen the hematoma here, and we have done cortectomy for the thin cortex above the hematoma, and we have evacuated the hematoma. This is another patient in which we have done frontal craniotomy, and we evacuated the hematoma. The results of cerebral corridor creator are far better than the first thing. That operation is a small operation and not big one in terms of time, in terms of the need for long surgical procedure and complex surgical procedure, because it can be done within few minutes. And the hematoma, you can see it coming out. Allow any new forming blood to come out. It is far less because we are doing it through peritoneum. But here, in the conventional way, we are doing it through craniotomy, and we are going to cut large area in the cortex, and so to see inside, and so it will be a little bit difficult operation. This is one of the patients. This is after the operation. You can see the hematoma, I think, was here in the left, the right frontal area, and has been evacuated, and recovery, especially in cerebral corridor creator utilization, are very rapid, and the patient will get more better than any other procedure. Another patient after the operation. The complications of cerebral strokes are the following. The most important are residual neurological deficits in form of dysphagia, in form of weakness, whether hemiplegia or hemiparesis, and the possibility of developing epilepsy, and also the psychological part like depression, defective memory. Also, if the hematoma affecting the visual areas or the hearing areas, the patient has this problem. I hope if I have done any good work for our younger colleagues to understand this problem and to understand how to deal with this problem. Thank you.
Thank you, Professor. It was really so amazing and fantastic. If you permit me, I'm gonna share you the questions, please. Okay.
Okay.
Okay. Someone asked, what are the indications for each specific surgical modality for management of ischemic stroke? Did you get it, Professor?
You may not have heard that. Abu Bakr, are you there?
Please repeat it because I didn't hear it. The internet
Okay.
is not good. Maybe from.
Okay.
Please
I'm
repeat
gonna-
the question.
Someone asked, what are the indications for each specific
Yeah.
surgical modality for management of ischemic stroke?
Did you get it?
Okay, I'm gonna share it to your chat. Okay.
You mean the
Yeah,
cerebral
that's-
revascularization?
No indication for I mean the for management of ischemic stroke. Indication for specific surgical modality for management of ischemic stroke. Just a minute. Okay.
Yeah, I'm
Definitely,
gonna,
the stroke
I'm
needs
gonna put it in
management.
your chat.
What is speaking about
It's in
Yeah,
your chat. It's in your chat, Abu Bakr. I just put the question in your chat. Can you check on your chat? Do you see it?
I have read the chat. Yeah. I have read the question. I think he is or she is asking about the indications for cerebral, mostly cerebral revascularization. And this is usually done in patients with early symptoms of the ischemia, like forgetfulness, like intermittent strokes or tics. In these cases, you have to study the cerebral circulation. There is normal level for cerebral circulation, and you can study it as I have said, by radioactive oxygen. And if you have seen that the circulatory volume of the blood in certain areas of the brain is defective, is below normal by relative ratio is below normal, you have to increase it by cerebral revascularization, or otherwise that area might develop severe ischemia and you cannot reverse it. We have to do that before development of severe ischemia, because if we wait, that might happen. This is a recent way of management. You don't have to stay till development of permanent ischemia.
Very good. There are a couple of questions. Ahmed, do you see them? Okay. Do you see them? Does the volume of infarct influence the decision of making anastomosis? Did you hear that, Ahmed?
Well, you are speaking about the indications of cerebral, okay?
Yes.
someone asked about when we use flow. Sorry, just a minute. Yeah, low and high flow anastomosis. When we use it, I mean, when we do it.
We use it after studying of the cerebral circulation and to know the amount needed by that part of the brain. We know that the brain has perfusion, which is in certain amount that should be applied. If that amount has been reduced by a minimal amount, you can use low flow. If by a big amount, you can use high flow anastomosis. Also, I have seen here a question about the indications of external ventricular drainage in cerebral hemorrhage. You can use this as a drain for that hemorrhage. But as I told you, in using this procedure, because the hemorrhage is sometimes is clotted, the frequent blockage of that device. There are certain, sometimes there are some patients who are they are very irritable and they are going to remove that device. And also there are possibility of infection. It is used when there are no facilities. I think so now after the cerebral corridor creator. I think the external ventricular drainage, I have tried it for a long time, but I didn't find it superior to the external ventricular drainage. If the hematoma is too small, you need neuronavigation to go to the hematoma by using EVD or external ventricular drainage. If the hematoma is too large, you say maybe you don't need neuronavigation, but you are going to be faced by frequent blockage of the catheter. So I don't know. I don't advise it so much.
You know, I'm glad
Okay,
to
do
see
you
that.
hear me?
Go ahead, Ahmed. Go ahead, Ahmed.
Should I read much more questions?
Yeah, there's another question. I'm glad to see it's very interactive, Ahmed. And we have another question from Chizawa. Chizawa, could you please introduce yourself and ask your question? His camera's working. Go ahead, Chizawa, go ahead. Unmute and introduce yourself and ask your questions.
Okay, good evening, sirs. I'm Dr. Chizawa Ezeaku. I'm a surgical resident from Nigeria. I don't know if I'm being heard. Can you hear me?
Yes, we can.
Okay. My question is in terms of surgical evacuation, are there specific criteria for patients with hemorrhagic stroke to be candidates for surgery? Or is it every patient with an intracerebral stroke that are candidates for surgery? Or are there criteria with regards to the volume of the hematoma, neurological deficit, or the likes that makes those patients merit surgical evacuation? Thank you, sir.
Definitely not any patient is a good subject for that, for different procedures of evacuation. If the patient has only a small hematoma, might be 1 centimeter by 1 centimeter, that is not a good indication for any surgical intervention. In this case, the bleeding vessel is small and the body will neurological deficit is also small, and the patient is expected to benefit from conservative treatment, including reducing of the blood pressure, cerebral stimulants, and physiotherapy, and this. Actually, the evacuation of the hematoma means that the hematoma has certain peculiarities to be evacuated. For example, large hematoma and hematoma near to the cortex of the, because here I'm not going to cut so much structures while you are going to the hematoma. Otherwise, hematoma endangering the patient's life because of the rapid collection and the need for control of the bleeding vessel. And these hematomas are usually occurring in all population, but the age is not a factor in decision of what to do. If the hematoma is progressive and endangering the patient's life, and it has any superficial part near to the cortex or near to the skull, it is better to be evacuated surgically, and not any hematoma.
Thank you, sir.
John, are you there?
Yes, I'm there. I'm trying to figure out how to get Dr. Ajiber.
Yeah. Yeah.
You in, Dr. Ravager, yet? Okay, he should be coming in now.
He's there.
Okay. Okay.
Hi, Professor.
There he is. Thank you, Abu Bakr.
Oh, thank you.
He's going to say thank you, Ahmed, to Dr. Abu Bakr in Sudan.
Yeah, of course. It's really amazing, and I'm so appreciated for being with us, Professor.
Thank you.
Okay, next
Hope to
speaker.
see you again later.
I'm so appreciated, Professor. So now with Professor Jaber, I think he's muted.
Hello, good evening, everyone.
Yeah, you can go ahead.
Okay.
All of you, did you hear me?
Yes, we can hear you loud and clear.
Okay, thank you. So I'm going to talk about the anticoagulant per se and to be used in the neurology.
Okay, Professor, but first of all, I think Ibrahim must introduce you. Ibrahim, could you introduce Professor, please?
Yes. Hello, Dr. Prof. Nuruddin Al-Jaber. Thanks for participating in this webinar, which is related mainly to the stroke and its management. We have our guest, Prof. Nuruddin Al-Jaber, who is the professor of cardiology in Sana'a University and the head of Military Cardiac Center and the scientific officer for the Yemeni Cardiac Board. We are very appreciated for your participation today in this webinar, and we all were willing to listen to the details you are going to provide us. Thanks again for participating with us. You can go ahead right now. We all hearing.
That's okay, thank you. Good evening, everybody. I'm going to talk about the anticoagulant in cerebrovascular stroke. All of you are hearing me. Okay, did you hear me?
Yeah, we do, yeah.
Your
Okay,
voice
the
is
slides
clear
is
right now.
clear.
Yes, the slide's here.
That's okay. So I'm one of the members of the Yemeni Heart Associations. I have nothing to disclose regarding to this talking. So the relation between the neurologist and the cardiologist are frequently involved in coordination and in patient with a variety of conditions that the most common being is stroke. So the neurological complications of cardiovascular system disease involving the brain is stroke, cognitive impairment, and the brain infarctions. Many cardiac conditions can affect the neurological system, including that atrial fibrillations, cardiomyopathy, valvular heart disease, and intra-atrial septum abnormalities, and so on. Even change in the blood pressure, and so it may affect the neurology. So how do you think it is simple way? It is really better to give anticoagulant neurological disease, which type of anticoagulant we are going to give, and what time to give it, how to monitor it, and what are the side effects of such drugs. There are a full rule to give drugs should be kept in mind. So it is simple, but it's not easy. All of these. This is the simple case which you showed in this movie. This is heart disease with big thrombus inside the heart. So you can see this is a big thrombus inside, so it may attack or involve the brain. Usually between us and the neurologists, a lot of cooperations to help the patients. One of the baddest stories that you can make it, these patients is around 45 years old female patient with rheumatic heart disease, a common disease in our country, and she get bad complication in stroke, diagnosed by spot diagnosis of a stroke, what we call the fast assessment. So we are afraid of such patients with anticoagulant at the beginning, but you see what's the bad complications coming is happening to her. So again, if we give her the anticoagulant not in a proper dose, in a proper manner, the bad things also, it will be happening for these patients, and she may get also bleeding, even cerebral bleeding. The sequences of thrombosis, so start from the simple spasm, and then the plaque formations, and then the coagulation. So according to the what we call the Rutherford-Fairchild, so that's mean if there is facial wall injury and hypercoagulability state, circulation stasis, it will involve the circulatory system leading to thrombosis. As you know that the manifestations of thrombosis that may affect the systems. So we're concerned about the stroke or TI or intracranial stenosis, which may be also the clinical manifestation of stroke. They are like what we call a leading cause of death in a patient. As you can see, a thrombosis take the majority of the cases which are liable to death. There are many types of antithrombosis using as therapy. So the treatment of thrombosis either to prevent thrombosis by anticoagulants or antiplatelets, or to removing the occlusion or angioplasty, or even to do vasodilatations by nitrate or calcium channel blockers. The antithrombotic mechanisms, they are different. Either it is prevent clot formations and its extensions, antiplatelets drugs, which is interfere with platelets activity, thrombolytic agents, dissolve existing thrombus. So this is the antithrombotic drugs, how it acts. Antiplatelets, usually either it will act as the primary prevention or secondary prevention for the clot or thrombosis or embolus, which is happening in circulations. And you can use the thrombolytic therapy if you solve such thrombosis. The diagnosis requiring anticoagulants as a cardiac disease, there are a lot, like atrial fibrillations, valvular heart disease, prosthetic heart valve, deep venous thrombosis, pulmonary embolus, hypercoagulability state. There are also many patients, they are going under surgery for a long time, like hip fracture repair, pulmonary hypertension. Such patients, they need anticoagulants, and we should deal with them. So there are many studies either to give anticoagulants or not. So the better things, the favorable anticoagulant this patient, and this is also known facts. So it will lead to reductions of all causes of mortality, also lead to reductions of stroke. If we get in acute situations of ischemic stroke, what we are going to do, that they use tissue blood, and it was in 1995, the NEDS study of TBA, they proved that it will benefit if you're going to use it, especially in early hours if you use such TBA as anticoagulant. They made a study including all the data for these patients, and they conclude such drugs, it is very important in early stage of cerebral thrombosis. So it is just, you may use it to be used as a class 1A indications if the patient is coming early and proving that the arterial occlusions with using CT or MRI is the proper management. Other points of stroke management, like aspirin therapy, also by many studies, they prove to give aspirin in the treatment of stroke, and there are a lot of randomized trials to use it for such patients. And nowadays, it is common facts, and all doctors, they know these facts, and they use it in patients with strokes. unless there is contraindications. The international stroke trials also, they prove this fact using aspirin and heparin in such cases. So they conclude that aspirin, it will be give a significant reductions for recurrent stroke patients, and even it decreases the death and for further progression or further use of aspirin. We are going to think about full anticoagulant with IV heparin and low molecular weight heparin. You use it, it's not recommendedly used by American associations and other associations. So unless there is a good indication of these patients and they have a proper following of these patients. And there are different stories and different ways to give heparin and in such patients. So either to give it during the early emergency and even to shift it to other anticoagulants, like the common one is warfarin. So for a patients, we are going to give such patients anticoagulant if they are developed even non-cardiac embolism of a stroke or TIA. It is also recommended to use antiplatelets or anticoagulants, which could be considered to be class 1A indications. The story of anticoagulants, how to be used, they start in 1930 by heparin, and it's going on like that until 20s. We are going to use the new oral anticoagulants or novel anticoagulants like dibigatran, rifaroxaban, and apixaban. Why they thought of these new anticoagulants, because of a lot of disadvantage of current anticoagulants warfarin, because it is the neurotherapeutic index, need for frequent monitoring, and the slow onset and offset of action, the route of admissions, large inter-individual dosing differences, drugs and drugs interactions is many, and we have some what you call genetic polymorphism. The complications also, it is more bleeding or neurothrombosis, induced thrombocytopenia, warfarin, necrosis, osteoporosis, and warfarin embryopathies in a patient. You use it in pregnant ladies, we should keep it in mind. This is just to remember the cascade of coagulations, either intrinsic or extrinsic pathways, and you know where it is working, that the vitamin K sensitive factors, and we have used the oral anticoagulants like warfarin working in this factor 2, 4, 7, 9, and 10 factors, and also it will affect such way. The optimal using of anticoagulants, it depends on IN, especially in atrial fibrillations. The ratio between 2 and 3, it is a good one to reduce either stroke and to not the patient develop intracranial hemorrhage. So there are many risk factors for stroke and systemic complications, like the previous stroke, diabetes, history of hypertension, heart failures, and an advanced age. All of these, they have they are liable to get infarctions. So this is one of the cardiac patients. You see here that he had a thrombus atrium. Such patient, they are liable to get stroke more than the other people. They 5 times in atrial fibrillations compared to those patients have atrial fibrillations. Stroke during atrial fibrillation is twice as likely to cause death and disability compared with non-embolic stroke. Patients' treatment score to give them stroke, there are many scores they use. They start by SHAD-2 score. So this is simply the congestive heart failure. Patients have age more than 75, diabetes, and stroke, and they give this scoring 1, 1, 1, and the last one is stroke. And they 0 point, the low risk, 1 to 2 is moderate risk, more than 3 is high risk. So if you see the total score, the score is increasing, the liability of patients to develop the stroke, it will be high. Then they develop what we call SHAD FAST score. They just increase it by stroke, vascular age, they're becoming more 65 up to 74 and 6 categories. Again, if you see the study, how it will be when the SHAD-FAST score is increased, the liability of patients to get a stroke, it will be more. So either it is SHAD or SHAD-FAST score, both of them, they just agree in this patient, they will develop of the score is high. So what we are afraid from the bleeding risk score, it is widely used many score to assess this patient is liable to get bleeding or no. There are what we call is hemorrhages or has bleed or atria score. And these scores, they have these different items. Usually the score is a common, it depends on that the patient is hypertensive or abnormal renal or liver functions, stroke, bleeding. The INR is liable, is not, you cannot adjust it properly, elder age, or have different drugs which is interfere with patients or patients is liable to get from such anticoagulants by use the has bleed score, and you should adjust the proper anticoagulant to use it. To use it or not to use it, effective not to bleed. So that's mean we are going to do balance between what's inside the heart and brain affections. Usually the older anticoagulant, like warfarin, is very effective, easy reversible, not expensive. But we have different sequelae. The slow onset of actions need regular monitoring, interactions of food and other medications, titrations are regular, dose adjustment, it should be there. So there are many bad warfarin use, like reason why the physicians, they don't want to use Coumadin because of risk of bleeding or risk of embolus, or patients refuse to use it because they are afraid of complications, inconveniences of monitoring. So we cannot monitor it properly, impair quality of life sometimes. The aspirin is superior in some patients, and the cost, which is not that big dilemma if in such thing. And there is what we call DAO. So the different thinkings of using anticoagulants, the cost and risk of embolization, so we can deal with it. So what they think of, I think that you are going to use an ideal oral anticoagulants. So the ideal and oral anticoagulants should be required no remote monitoring, have a little interactions with food and other drugs, over a good safety profile with regard to the bleeding risk, and have similar efficacy in reducing thrombotic events, reach thrombotic levels within several hours. And even IV administrations usually prefer oral, ability to inhibit free and close bound thrombin, available of antidote. So they are just thinking of the new oral or the novel anticoagulants. So they have different mechanisms. They work what we call in factor 9 or factor 2 prothrombin factors. The rifaroxaban and apixaban, they work in factor 10, and the dabigatran, it's work in factor 2. So that they are working in such things to inhibit such factors, and there are many studies they're supporting this, and the difference between different type of anticoagulants, apixaban or rifaroxaban or other new ones. So it is not that of big deal, and there are many that support these drugs to be used. All of these study, like EF study, Aristotle studies, all showed non-inferiority compared with vitamin K anticoagulants, better safety, and even the bleeding risk or the intracerebral hemorrhage. So if we do this, is the comparisons between the different use of anticoagulants, warfarin, dabigatran. So if you see here, the major bleeding is coming from the warfarin, and even the complications, if you compare it, warfarin, it's more complications. Between warfarin or rifaroxaban, what we call rocket trial, if you see that the other complications, they are more with warfarin rather than rifaroxaban. The things for apixaban, so if you see again the mortality, major risk, intracerebral hemorrhage, and even the embolism is more with warfarin rather than other rifaroxaban. So all cause stroke systemic embolizations, they prefer to use the new oral anticoagulant, whatever it will be, better than the warfarin. If adverse effect like major bleeding is more with warfarin rather than the other or the new oral anticoagulants. So we are going to use it, and it's better in stroke, and you know how to follow up with the patient, and easy for the follow up, and it's not all of that compared to the warfarin. It will be better. The one point of reversal of such drugs, it's not there. The warfarin, it is easy to be referred by the vitamin K or glutamine sulfate, or gas plasma and other things. But the new oral anticoagulant, we don't have the, the ideal management for reversing such drugs, which is even it's not available in different countries like our country. So we just use such anticoagulants because of safety, because of any other things. So the general rules, if we are thinking of such things, to assess the vital sign and resuscitate the patients, if we are going to reverse this new oral anticoagulants, withdraw anticoagulants, periodic assess of the patients, do gastric lavage of the drugs. If there is so it will be admitted to the hospital and managed accordingly. Actually, there is non-specific, what we call pre-homeostatic agents like activated prothrombin concentrations. They may be used, but this type of management is not available in every place. So that's mean if you are going to use such drugs, you have to do proper monitoring of patients and following the patients. Switching, if patients have coumadines or low molecular weight heparin or unfractionated heparin, it is easy to switch them to the new oral anticoagulants. So if the patients receiving coumadin, if they are R less than 2, immediately you can switch. If it's between 2 and 2.5, you switch it the next days. More than 2.5, just wait for the ANR to be reduced and then switch. Low molecular weight heparin start at the time of the next switch simply. Unfractionated heparin start at the time you stop heparin. Switching from the NOAC to warfarin, so you can start both ANR closely, discontinue NOAC when the ANR more than 2, to switch to unfractionated heparin or low molecular weight heparin start them at the same time, and then see the effect when the ANR is increased to another to another switching to another NOAC start at the next bill of the drugs. There are what we call dual antiplatelet therapy. We can use it instead of NOAC in patients who cannot receive such anticoagulants. Again, you may use it with no. So the double, what we call double antiplatelet versus oral anticoagulant, we may use it clopidogrel with plus aspirin versus oral anticoagulant for atrial fibrillations in a patient. This is a trial for prevention of vascular events, what we call active W trial, control trial. But actually, we have to keep in mind that if the patient is high risk for the embolization from atrial fibrillations, we should just keep in mind this patient, it will not be of value. So there are different studies to compare either clopidogrel with aspirin rather than oral anticoagulants. They again, we have to use it with a cautious in such patients, because if you are afraid of this patient is you cannot control it, from you're afraid from major bleeding, so you should keep in your mind such. And these are many different studies. They are supporting such things in management. So sometimes we have patients who use triple anticoagulant therapies, especially in those patients with the coronary artery disease. But again, close monitoring of such patients and follow-up of such patients, it will be of good value to keep these patients in gas receiving and the drugs and lead. Even such patients in atrial fibrillation and stenting, so this patient, they are liable to get triple anticoagulants. But again, using these anticoagulants should be with the proper follow-up management, the proper observation of these patients. So there are many things that you select these patients for anticoagulants, and we have to use just the SHAD score. This is just simply sometimes how if SHAD score is 0, you are afraid increasing of stroke risk. So we can use the non-antithyroid. We cannot use it. Patients are going to have or liable to stroke. So that you can start the aspirin, and then if it's more, the age is increased, more stroke, you can combine aspirin with oral anticoagulant. If SHAD score 1, you can use oral anticoagulant. If SHAD score is 2, oral should be used. Even use what we call the new oral anticoagulant, which is preferred rather than what. Again, you should know how to manage the oral anticoagulant. You should know the optimum dose, the follow-up of the patient, and even you just see the patient how he can deal with these drugs, how he can use the new oral anticoagulants or just to give him under warfarin, and you can follow up the patient's monitoring, the cost of patients, and even the patient's diet if it's trouble in it. So select for him which anticoagulant used to be in such different type of patients. Again, if the patient is receiving such drugs, we should just give him what we call effective patients educations, that you are going to use these drugs, try to monitor properly if it's using to oral anticoagulants like warfarin, try to talk with other doctors that you are using such drugs. If you are going to receive any other medications, or you are going to do any interventions, just inform. Sometimes we get what we call the dilemma between the heart and brain. So such case, if the patient had artificial bleeding, it is also one of the major tasks that the cardiologist and neurologist is. So that means we are going to give anticoagulants or not. The patient had bleeding and he had the pulse is there. So this is just, you will balance the situations, you know which type of anticoagulant, how to anticoagulant in such patients. So if the patients need anticoagulant and there is associated intracerebral hemorrhage, the N is low per year in patients with chronic warfarin anticoagulants. Again, keep in your mind that the risk factors, age, chronic hypertension, and leukocytosis, elevations of ANR, all of these you should keep in mind, and how to adjust all the things and to manage. They depend that the bleeding is major bleeding and the bleeding is the less, it is affect the patient's, and how to do it just to reduce the blood, or if you think that the patient is maybe need to use the vitamin K or use the fresh frozen plasma, and you use the prothrombin complex concentrations in the NOAC. So all of these, again, you keep in your mind, one eye on the heart and the other eyes on the brain. So again, you may use just heparin in small doses and follow up how the patients go, or if you need the interventions to evacuate the hematomas in the brain. All of these dilemmas, we should just do good collaborations between the cardiologist neurosurgeon, and even the neurologist how to use such drugs and how to monitor such patients. So again, there are what we call something you are going to use anticoagulants in the prophylaxis. Keep in your mind that these patients, you may use them in different ways, in different situations, and you need to follow such patients well. So at the end, what I can say, use thrombolytic or anticoagulants or antiplatelets when you need it. So the most of the causes of transient ischemic attack or stroke safely treated by antiplatelets or aspirin sometimes. When thrombus in the heart is evidence, anticoagulant is better. The new oral anticoagulants are better in stroke from the different studies which already mentioned before. Stratify patient with atrial fibrations by stroke risk, weight, bleeding, and risk in balance in such patients. Choose an evidence-based strategy when you can use it. Match the anticoagulant regimen to the individual patients, not for all the patients. Good collaborations between cardiologists, neurologists, and even neurosurgeon lead to outcome. So what the heart, it is all in your head. So sensorily brain, this is a message in the brain. So that's mean we have to consider it. I have a brain and a heart, and I'm not afraid to use them. So that's mean we have to use our brain for the heart and to make a good collaborations. Thanks a lot for you.
Thank you, Professor. It was really so amazing and informative. So, John, do you want to say anything?
Oh, no, thank you very much. This is the first cardiologist we've ever had on these webcasts. Congratulations. But it's certainly an excellent, it's an excellent platform, as you can see, Professor, to interact with people. And I'd like to give more of a chance. Is there anyone else that'd like to ask a question of Doc or make a comment? Don't be afraid. This platform is to be used, and it's going to get more popular with Chat GPT. Professor, I don't know if you've heard of Chat GPT, but if it's a more powerful platform, it's a more powerful platform. It's going to make a lot of changes to video and video production, video promotion. I don't know, has anyone ever heard, have you heard about the Chat GPT? We're going to start to incorporate it into Neurosurgery TV. We're going to start to teach it too for neurosurgery. So, because you guys are busy learning neurosurgery. Okay, Chizawa from Nigeria, welcome. Are you there, Chizawa?
Yes, I'm there. Good evening, sir.
Yeah, I'd like to thank you for coming from Nigeria, and you're welcome to come to any of our webcasts.
Thank you so much, sir.
Okay, anyone else would like to introduce? Go ahead. Go ahead.
Dr. John, excuse me, there is a question in the question bank.
Oh, okay. There's a question. Go ahead.
It's a question to the Professor Nuruddin Al-Jaber. It says, how can I decrease the increase in intracranial pressure using medications like mannitol or dexamethasone? Do you have any comment?
Okay, thank you. Actually, these drugs, they are not used to reduce the intracranial hemorrhage. They may use it in decrease the intracranial tensions. But actually, when the hemorrhage is happening, it's difficult to manage. So keep in considerations how to deal with the patients, not only to decrease, not to make it more increase. To decrease it, it will resolve with time, but just not to make it to increase. The drugs, which is monitors, steroids, and the other things, it will not affect such things. I think so.
Okay, thanks.
Okay. Next question. Do you want to monitor? Do you have someone to monitor, Ahmed? Or do you want to pick the next question? There's a couple of questions there.
So I'm really giving the tokens very in a hurry because it is long talk. So I try just to make it short with the time.
It's very informative.
Okay, thank you.
Okay, Ahmed, take charge. Come on, let's go.
Okay, I'm just waiting for someone to ask, or if someone has a comment or a question.
Yeah, there's
So
a
it's
couple questions there. You gotta pick one that's appropriate.
which one? I couldn't see
Okay.
anyone.
Okay.
Okay, I can't see any new question.
Oh, you can't see any? Okay, I thought I saw. Does
I
anybody
have
have
a
a question? Go ahead, go ahead.
I have a question, please. Dr. Professor Nuruddin Al-Jaber, after patient of ischemic CVA, they usually use blood thinners like clopidogrel and aspirin, but one of the common side effects is bleeding. So how can you minimize this risk or complication due to using aspirin
Okay.
or clopidogrel?
Okay, thank you. Aspirin and clopidogrel, it's not that the drugs actually cause bleeding. They are simple drugs that will not, their major complications of bleeding, and it is the safest drugs to give it in patient with ischemic stroke. But actually, when we give such drugs, when this patient have thrombosis or had recurrent ischemic stroke from that atherosclerotic change or something. But if the patient's having other cause of major stroke like atrial fibrillations, or the patient with artificial valves, or had intracardiac thrombosis, the idea is different. These drugs will not work, will not act. So this patient or those patients, we need to use the oral anticoagulants in them. Aspirin again and clopidogrel, they are safe drugs. They are not cause of major bleeding. And again, even we should just follow the patients. We see how it will. Thank
Okay,
you.
thanks.
Yeah, man, where do we go from here?
Okay, to me, I think it's all. So I want to ask.
One, I'd like to say hello to Ahmed Pirzad from Afghanistan. Are you there, Ahmed? I'd like to introduce him, Ahmed. Ahmed, are you there? Ahmad from Pirzad from Afghanistan?
Yes, hello. Yes, greeting. Yeah, this Dr. Pizot. Our internet is not good. Sorry.
Okay, I can see another question here in the question section.
Go ahead.
Professor Nuruddin, this is a question which says, what is the anti-aggregation and
Sorry, our internet is not good.
Okay,
what is the what is the anti-aggregation and anticoagulation schemes during hemorrhagic stroke? Is there an approach?
Yeah, hold on, Ahmed. We'll talk to you later. Okay.
Okay.
Ahmad, we'll talk to you later. We have a question now. Go ahead. Ibrahim.
Let me just say it again.
I said the
Professor
question.
Nuruddin, what is the anti-aggregation and anticoagulation schemes during hemorrhagic stroke? Is there an approach or a guideline to use this medication during hemorrhagic strokes?
I think such medication, it was used before, but nowadays, if there is hemorrhagic stroke, I think I'm not the neurosurgeon to answer more completely, but they depends on size and site of bleeding. So if the bleeding is big bleeding and it is accessible to be evacuated by the neurosurgeon, they should do. If the bleeding it is inside, it's difficult to be manipulating or just evacuating by surgery. So such patients, they will be under conservative management. So this means us to remove any cause of bleeding, to follow the patients, to adjust their blood pressures and the bleeding, if it's just, little, not cause more damage or more bad sequelae, it will be resolved with time. Thank you.
Okay, thanks for your answer.
Ne Jordan Barawi. Thanks, Jordan Barawi. پنجصدی راویسه نه پنجصدی رو خود دادم چرا دادم پنجصدی چرا دادم
Okay, Ahmad, I'm sorry, I can't mute you here. There
نه
we
نه
go.
چرا
Okay.
دادم پنجصدی رو باز راویسه
Man, I
به
don't know
چی
what's
دادم
going on.
Another question here.
Go ahead. Go
الو
ahead.
Mr. John, can you mute the other participants? It's a little bit noisy right here. Mr. John? Yeah,
Yes.
now everything is fine. So we have another question.
Yes,
here.
go ahead.
It says to Professor Nuruddin, there is a question that states when to start anticoagulation in patient with atrial fibrillation and ischemic CVA. The time he's asking when to start these medications.
Yes, I get the point. Thank you. So if the patient's in atrial fibrillation, immediately you have to start anticoagulant for them, not to wait. In atrial fibrillations, again, we have different type of atrial fibrillations, but actually we are afraid from the getting bad complications of for stroke. Usually in atrial fibrillations, they said that we have to treat the brain, not the heart. So we have to just, to protect the brain, not the heart. So we have to start immediately if we discover these patients have atrial fibrillations. It depends also what type or what the cause of atrial fibrillations. So if the atrial fibrillation is coming with rather than non-valvular heart disease, like patients with hypertension, myopathic heart, this patient, they are, or even valvular heart disease with mild to moderate form, they could be treated, these patients by the new oral anticoagulants. Patient with artificial valves, with atrial fibrillations, or patient with severe valvular heart disease, like severe mitral stenosis, those patients till now, no study proved that use the new oral anticoagulants. They usually use the warfarin in such patients. Thank you.
Okay, thanks.
Okay, Ibrahim, any more questions?
No, these are the rest of the questions. I can no longer see any other questions. Is there anyone else who would like to participate? To ask, to give a comment?
Or just to say hi?
Yeah.
Okay, hi. I don't have question, but I just want to thank the president of Walter Eden Yemen for the invitation, for inviting the students to participate in the webinar. We are highly appreciated for the collaboration of the webinar. Thanks a lot, and we hope to hold more upcoming webinars together with them, inshallah. Thank you so much for the invitation. We are highly appreciated.
Yeah.
My
Yeah,
pleasure. Thank you.
Yeah, we encourage all people from Nigeria. They're always welcome to come to these webcasts that are run pretty frequently by Ahmed. So you're welcome to come back. Okay, Ahmad, go ahead. Do you want to take it forward here?
Okay, I think I have to, we may reach the end. So I would like to thank each one attend this webinar, and of course for the speakers, Professor Nuruddin Jaber. He presented the most informative and amazing lecture in neurology and in cardiology at the same time. So thank you so much. I would like also to thank Professor Abu Bakr Daraj and also the organizers, dear Ibrahim and dear Abdulrazak from Sudan. And of course, thank you, John. Again, without your support, we couldn't do anything. So we also appreciate it for your support. And in the coming few days, there will be another webinar with another topic. So thank you all.
Okay, thank you very much for arranging this whole thing, keeping that part of the world open to this wonderful technology. We had a panelist from Uzbekistan. So Zolkian, can you talk at all? Can you say hello? Are you the first time we've ever had anybody from Uzbekistan, as well as Afghanistan and Nigeria. So we're breaking some barriers, Ahmed. So, okay, very good. And the next webcast, you want to show the banner? Ahmed, do you want to talk about that next webcast? When it is and what's going to be covered?
Okay, do you mean next?
Yeah, put the banner up. You have the banner there you can show us? Do you have it ready, handy at all?
Okay, are you talking to me or to the Afghani one?
Well, the next webcast. When is the next webcast?
Oh yeah, okay. Till now there is nothing ready, but I'm in contact with maybe 3 neurosurgeons. Professor Nasser Randour. Inshallah, if he is ready, I'm gonna organize with him a webinar. Someone from Jordan and another one from Oman, but this may take time. And if there is, if that is really ready, I'm gonna tell you and let you know soon.
Okay, now that someone is asking a question
Okay,
about how to become a member of Walter Dandy.
Who is talking?
Someone asked a question, how do they become a member of Walter Gandy?
It depends on your country. If there is a Dandy Club in your country, you can contact them. If not, yeah, you can contact me, and then I'm gonna help you to establish a Dandy Club in your country. You're okay from India. Okay,
Yes.
I'm gonna check if there is a Dandy Club there. I'm gonna let you contact with them. If there is not yet, okay, you can contact me on email in order to help you to establish a Dandy Club there.
Okay, when is the call open for Sudan? What do you mean, Saida? Can you tell us what you mean by that?
I'm sorry to interfere. I can say goodbye for everyone and see you, inshallah, in next meeting.
Okay, thank you, Doc. I know you're busy. Thank you for your time.
That's okay. Thank you. Thank you. Bye.
Thank you. We also appreciate it for you.
Okay, I guess we'll close now. Go ahead. Did someone want to talk?
I'm Said Al Fatih. I'm first year medical student in Abdurrahman Islamic University. I'm asking when is the membership call for Walter Dandy in Sudan Club?
Okay, I didn't understand that. Did you understand that?
yes.
Ahmad, yeah, you're gonna have to wait till you get a better connection. Okay, we can't hear you at all. I believe someone just asked a question, correct? Did someone just ask a question? Saida Al-Fatih, did you ask a question?
Yes, sir. I'm asking about the membership call.
Okay, Ibrahim, could you answer that, please?
Yes, yes.
I can answer this.
Ahmad, I have to ask you to stop interrupting. Ahmad, the
Excuse, I would
connection's
like to-
terrible and you're not helping the webcast.
Thank you. But I would like to answer the question from. She asked for the membership from Sudan.
Okay, I guess it's getting a little chaotic. Okay, thank you, everybody. I'm gonna go off the air. I'm gonna stay here to talk to people, but I'm gonna go off the air. So thank you, everyone, very much, and stay here if you want to chat. Okay, we stopped the recording. And, okay, we're not recording. Okay, we're off the air now. That was a good turnout, Ahmed.
Okay, yes. Mr. John, she is asking about the membership, the opening for new membership of Dandy in Sudan,
Oh, okay,
not in Yemen.
okay. We have the
So,
rep.
do we have the Dandy officer, the president of Dandy officer in Sudan is the best to answer this question because he knows the timeline for the opening for membership.
Okay, oh, there's a representative from Dandy here now.
I think
The president of Dandy Sudan, is he
Yeah, who was
available?
who was the Dandy representative from Sudan?
Abdulrazak, but he's no longer here.
Oh, okay. And Saida Al Faith, Fatih, did you have your question answered?
Okay, let me help her.
Okay, there's a
Okay, I'm
doctor
gonna share
from
my.
there's a doctor from Uzbekistan that wants to connect. Did you see that, Ahmed? There's someone from Uzbekistan that wants to connect. He probably wants the address of Dandy. Zolkajan, I guess you can't talk now, right? You probably don't have great connection from Uzbekistan. Oh, okay. So you're exchanging contacts now, right? That's good.
Okay. Thank you, colleagues. I'm Doctor and Assistant Professor in Uzbekistan. I am a neurologist. For me, very interesting. You are at the conference. I'm every time problem.
Yeah, welcome to Uzbekistan. This first time ever.
No. I am not first time. I'm every time.
Oh, you've been. Oh, okay.
Thank you so much.
Okay. Someone asked, is there a chance for CME? We don't have it set up now, but I don't know, Ahmed, do you have something to say about that?
I think no, this time not.
Okay,
no.
time or not, Northern, I guess.
No, we don't.
Well, because let me explain, when people want CMEs, that means we have to hire someone to take emails and email them out. So we're not ready for that yet.
Yeah, of course.
Hopefully in the future, we'll be able to hire a secretary to do that.
Actually, we had in the previous webinar, we had certificate for the attendance. Yeah.
Oh, okay. You can take care of that, Ahmed. That's up to you.
Yeah, of course, we had that, but this time we don't. Maybe in the next time, inshallah.
Oh, okay, because there's someone that can someone get our credit for now? Do you have any to give now, Ahmed, or are you gonna wait on that?
No, we don't. Unfortunately, we don't.
Okay. Okay, very good. Thanks, everybody, and we'll be in touch.
Thanks, John. This was really
thanks,
a nice
everybody.
webinar.
Thank you very much for participating. And thanks, Felix, and thanks, Uzbekistan, thanks, Afghanistan, thanks, Nigeria. Adios.
Thanks, John. Goodbye.